Uh, Very good morning, everyone. Welcome to Indian Society of Gastroenterology Masterclass with yet another talk on how do you manage ascites. But last week we had a talk on very common GI symptom, belching, hiccups, and proctalgia. And this lecture was delivered by Dr. Amit Datta, and this was a mastery lecture on these common symptoms. I hope you enjoyed listening to Dr. Amit Datta. Thank you, Amit, for a wonderful lecture. This week, we have chosen a topic which is extremely common, that is ascites. Although we know much about ascites and we treat in our clinical practice every day, but we thought that there are certain points we wanted to highlight in management of ascites, and some of these points will be highlighted by the speaker today. And the speaker today is Dr. Akash Shukla. Dr. Akash Shukla is a dear friend, and he's a professor and head of gastroenterology at a KEM hospital in Mumbai. And he's a very renowned speaker. The clarity of thought he has on the topic he speaks is remarkable. And we look forward to listen to Dr. Akash on this topic. Dr. Akash will discuss mainly about ascites which associate with cirrhosis, and he will just go over general approach to ascites. And to moderate this session, we have yet another legend, Dr. Manoj Sharma. Dr. Manoj Sharma is a professor of hepatology at ILBS in New Delhi. Again, Dr. Manoj is a very esteemed teacher and very learned hepatologist. With this, I welcome all of you again, and I request Dr. Saraswat to speak to you, and then he invite Dr. Akash Shukla for the talk. Dr. Saraswat, please. You're muted, sir. Sir, you're...
Yes. Thank you very much, Govind. Good morning to all the participants and viewers all over the country and from our neighboring countries. It's been about 3.5 months now since we have been running the ISG Masterclass, and it is, as ever, it is heartening to see the constant committed participation that we have from our audience. Our numbers have stabilized somewhere between 800 to 1,000 participants for every live session. And we have a core group of the audience who we see on every masterclass asking a lot of questions. And it is encouraging to see that they find that they are benefiting from this, and thus they keep coming back to our sessions. I think one of the key things that has held the attention of people is that our focus has been on common problems that we deal with regularly. And we have had excellent presentations from the top-notch speakers from the country in these last 3.5 months. In this 22nd presentation in this series, today we'll be talking about ascites. As Professor Makharia just said, ascites is an extremely common, and most people think of it as a very straightforward presentation. And in your early years, you think there are few things easier to manage than a cirrhotic patient with ascites. You simply have to give him a few tablets and drugs, and the fluid mobilizes promptly. Well, as you go along, and as I've said repeatedly to my residents who've been through SGPGI, I think the ultimate test of how good a hepatologist you are is how well you manage your ascites patient without swinging on the one hand from the extreme of large tense ascites requiring paracentesis, on the other hand to a dry, dehydrated, comatose patient with kidney injury. And not just how well you manage, because the number of drugs are limited. The insight into the topic is very important, and your ability to communicate this to your patient so that your patient is able to do good self-monitoring at home is probably equally important to avoid complications. And to take us through all these complexities of what is otherwise considered a very straightforward topic, we have Professor Akash Shukla. I've known Akash now for what, 12, 15 years, Akash? And it's been a great pleasure to watch his moving up the academic ladder to heading the Department of Gastroenterology at the KEM Hospital, Mumbai. He's a well-recognized figure on the gastroenterology, hepatology scene in India. And Akash, not only has he grown in his academic stature, but he has grown otherwise also in other dimensions also. I think whenever I go and visit him in Mumbai, it's one of the things I look forward to is the different eateries we go to, and everywhere Akash has commands a unique his presence, immediate attention and service. So if you wish to enjoy yourself in Mumbai, Akash is the man for you. So with these few words, Akash, I think we look forward to listening to your usual incisive presentations and to take us through this topic of ascites. Over to you, Akash.
Thank you, sir. Good afternoon, everybody. It's indeed a pleasure to be giving this talk in presence of Professor Saraswat, who has done such pioneering work in ascites. And also, I would like to acknowledge the contribution of other gastroenterologists from the country who have worked a lot on ascites, especially Professor Virendra Singh from PGI Chandigarh. He has, for the last 20 years, been working constantly in this field and contributed significantly to the development of ascites. In the next 40 minutes or so, I would like to, make the topic complex and then simplify. That's what I'm supposed to do, so that you get better insights on management of ascites. I will try to keep my talk as practical as possible while giving you just a sound theoretical basis of why we are doing what we are doing, because at times we tend to treat the pathophysiology of the patient rather than treating a particular diagnosis. And I think this is very, very true for ascites as compared to any other disease. We all know that ascites is a common complication of cirrhosis, and the prerequisite for development of ascites because of cirrhosis is the interrelated pathophysiological processes which contribute to the development of ascites. One is endothelial dysfunction. In the splanchnic circulation, this is excessive NO production, which causes splanchnic vasodilatation, and severe sodium and water retention, and finally, sinusoidal portal hypertension. Now, how these are four correlated with each other, let's briefly see. Now, because of cirrhosis, we know that there is increase in the gut permeability, there is increased bacterial translocation, giving rise to PAMPs, liver injury, which gives rise to DAMPs, which will then activate the innate immunity, giving rise to systemic inflammation, production of pro-inflammatory cytokines and reactive oxygen species, which then will give rise to splanchnic arterial vasodilatation. The endothelial dysfunction directly also will contribute to the splanchnic arterial vasodilatation. Although there is an increase in the absolute cardiac output, this is still relatively lesser than what is required by the body because of the vasodilatation, and this gives rise to reduced effective arterial blood volume. These two factors, splanchnic arterial vasodilatation giving rise to reduced effective arterial blood volume, would then cause activation of the vasoconstrictors and the antinatriuretic systems. That is the RAS, SNS, and the vasopressin. This gives rise to sodium retention, which will then cause fluid retention and produce ascites. Excessive water retention, out of proportion to sodium retention, produces the dilutional hyponatremia, and severe vasoconstriction, which is initially a compensatory mechanism to maintain the renal glomerular perfusion, when becomes excessive, will give rise to the hepatorenal syndrome. We all know that all these are again simplifications, whereas in reality, most of these happen in different proportions in each patient. Ascites occurs in 50% of the patients over 10 years of development of cirrhosis. The mortality is approximately 40% at 1 year and 50% at 2 years after development of ascites. The most reliable factors in the prediction of poor prognosis are hyponatremia, low arterial pressures, increased serum creatinine, and low urinary sodium. So let's come to how do we actually assess a patient who comes to us with ascites. So of course, we start with detailed history, and this is for the postgraduates who are attending. Two things which point towards the etiology of ascites being liver are reduction in the urine output. At times the patient realize it, at times the patient don't. But it is important that you elicit this history, because this is a very important history to point towards the etiology being liver. The second is if you find history of associated dilated veins over the anterior abdominal wall, then that adds to the diagnosis. Of course, if you get history of other features of liver disease, then that makes the diagnosis almost sure that you are dealing with liver disease related ascites. On examination, you want to quantify the amount of ascites, as well as you want to see whether the patient has tense ascites or not, and you would want to see for other features of liver cell failure. Platelet count is a very important indicator of advanced liver disease. Of course, you would order for a liver biochemistry. You would always do investigations to rule out other systemic causes of ascites. Especially, you would want to rule out renal causes, cardiac causes, especially when the history for liver disease is not there. The assessment of ascites itself starts with the ascitic fluid analysis. So that brings us to the big question of when do you do a diagnostic ascitic fluid analysis? So the standard advice of EASL and ASLD is for all new onset ascites. Now EASL says grade 2 and 3, ASLD says all new onset ascites. So for me, all patients who have significant new onset ascites should be investigated. Yes, if you have a minimal interbowel fluid, it is non-tappable, you can ignore that ascites. All patients who have been hospitalized require a diagnostic ascitic fluid tapping. Anybody who presents with a fresh complication of cirrhosis. So if a patient has GI bleed, hepatic encephalopathy, and has come to you with for the first time with these complications, then we must do diagnostic ascitic fluid analysis. But there are other situations in addition to these standard advices where I would always recommend doing a diagnostic ascitic fluid analysis. In a patient who comes with oliguria, you would want to rule out spontaneous bacterial peritonitis, and therefore, even if the creatinine has not increased, but the patient says that on the same dose of diuretics, his output has not decreased, I would always look for ascitic fluid analysis. Whenever there is a loss of response to diuretics, so patients who were on a stable dose of diuretics for a long period of time, did not have ascites, and now suddenly on the same dose of diuretics, despite being salt compliant, now present with ascites or worsening of ascites, then it is important to rule out infections, and therefore you would do a ascitic fluid analysis. When I examine my patients and I put my hand over the abdomen for palpation, if I find that the abdomen is warm disproportionately to the rest of the body, I would always do ascitic fluid analysis. Anybody who presents with pain in abdomen or even an unexplained worsening of LFT in a cirrhotic patient mandates a diagnostic ascitic fluid analysis. Not only you would look for HCC or portal vein thrombosis in these patients, but you would also do ascitic fluid tapping to look for SBP. Next question comes, where should we tap the patient from? Now, this was a beautiful article in NEJM which discussed in depth the three sites which are commonly used: the left lower quadrant, midline between the umbilicus and the symphysis pubis, and the right lower quadrant. Now, the advantages, or the conventionally preferred site was the midline, but the advantage which was for little chance of bleeding. The issues with this site is that there can be collaterals in the midline. If a bladder is hugely distended, you may inadvertently puncture the urinary bladder. And when you put in the needle is actually unstable. The left lower quadrant is the second site. The left lower quadrant is 2 to 3 centimeters cephalad and medial to the anterior superior iliac spine. So roughly this is 2 finger breadths above and medial to the ASIS. The advantage of this site is that the maximum amount of fluid is present in this area, and it is pretty thin. So it is easy to get fluid from this particular area. The disadvantage is in patients with severe constipation and loaded colon, the you may actually inadvertently puncture the colon. But this actually is the preferred site. The right lower quadrant, which was used some time ago, is 2 to 3 centimeters cephalad and medial to the ASIS. The disadvantage is dilated cecum, appendicectomy, adhesions. Both of these can create problems, especially patients who are on lactulose. They can have trouble. There may be adhesions of the bowel, and this can also produce inadvertent puncturing of the bowel loops. What do we do once we collect the fluid? Please send the fluid in both plain bulb and the EDTA bulb. If you do not send the sample in EDTA bulb, the cell count will be unreliable. I've seen very often samples being sent only in plain bulbs, and then the cell count is inadvertently low and does not correlate. In patients with liver diseases, we would always do a bedside inoculation into a blood culture bottle. Always inoculate sufficient quantity of acidic fluid. Most bottles will have a capacity of at least 15 ml, and that is the maximum that you can inject. So you please inoculate that into the blood culture bottle. The yield increases to 70 to 80 as per the usual technique of sending blood cultures. What is mandatory to do every time in acidic fluid analysis is the cell count, both total as well as the differential, proteins, and the albumin levels. What you can opt for doing in different circumstances, as per the pre-test probability, depending on the clinical scenario, you can ask for LDH and sugars if you're suspecting that there may be a secondary peritonitis. You can ask for a ADA, which Professor S.P. Mishra from Allahabad and others have shown high sensitivity for tuberculosis. Word of caution here, it is very useful to differentiate cirrhosis and tuberculous peritonitis, but it is highly unreliable when you have mixed ascites, where both portal hypertension related ascites as well as tuberculosis is present. And we have had some real life challenges when interpreting ADA in these patients. So when you have such a scenario, it is always prudent to look at either imaging evidence of peritoneal tuberculosis, or even better, the gold standard being a diagnostic laparoscopy to look at peritoneal tubercles. Malignant cells, if there is an appropriate setting, then you would send for malignant cells, you send at least 500 ml to a liter of fluid for this purpose. Then it will be centrifuged, and after the cytospin, then the cells are analyzed for presence of abnormal malignant cells. Amylase, if you're suspecting pancreatic ascites, pancreatic leaks, and then it becomes very useful. A level of more than 2000 would usually indicate presence of pancreatic ascites. Acidic fluid triglycerides to assess for chylous ascites. By and large, the triglyceride levels will be more than 200 in these patients. Very important question which is asked is, do you need to do correction of coagulopathy before tapping patients with cirrhosis? So beautiful article written by Professor Patrick Kamath et al. Wonderful study done way back in 2004, which looked at tapping for different groups of patients. So 84 patients had a INR of 2.5 and above. Another 208 patients had 2.1 to 2.5. Another 530 patients had 1.5 to 2. And similarly, platelet counts varied from 19,000 to normal counts. And almost 800 patients had a platelet count below 60,000. So that was a very, very interesting patient cohort. None of them received any coagulopathy correction. Now, the most interesting part was out of these 1,100 paracentesis which were done, where no coagulopathy correction was done, the tapping was done by well-trained endoscopy assistants. And there was no other, although they were being supervised by doctors, they were done independently by endoscopy assistants. 612 paracentesis were done with the platelet count below 50,000, and there were no procedure-related complications that required hospitalization. There was transient postural hypotension in 3 patients, leak which was self-limiting in 1 patient, and a traumatic tap which cleared spontaneously towards the end of the tapping in 1 patient. So total of 5 patients had just transient complications out of 1100, none of them having major bleeds, and our experience is also the same. So they concluded paracentesis performed in an outpatient setting by our GI endoscopy assistants is safe and efficient, even in the presence of thrombocytopenia and prolongation of the prothrombin time. So routine corrections are not needed. So are there any patients where we have to be careful? The answer is a clear yes. Which are these patients where you have to be extra careful? Patients who have fibrinolysis or patients who are in low-grade chronic DIC. So who will say that after doing blood collections, they tend to continue to bleed for a long time, or you will find a lot of blue patches on their skin wherever the phlebotomy has been done. Or if they are admitted, then at the point of central line, you'll see a gentle ooze happening. So all these give you a hint that you may be dealing with a chronic DIC, and these are the patients where you have to be careful. And a test like dynamic assessment of clot formation like thromboelastography is useful in these patients before you tap. Presence of renal dysfunction is another feature where you have to be cautious, because you can have qualitative platelet dysfunction, and that can give rise to increased risk of bleeding. If the INR is more than 2.5 and platelets are below 30,000, then you have to be cautious. And I personally would do a TEG in these patients before I go ahead with tapping. In the presence of sepsis, again, because they have low-grade DIC or fibrinolysis, therefore, you have to be extra careful. Very often people ask me USG guided tapping or just percussion based tapping, which is better. As long as you understand the anatomy of the inferior epigastric artery, I think it is not much of a difference between a blind tap versus USG guided tap. Our experience is that most of the times, even the small collaterals are missed on ultrasound. And in fact, to be honest, we have seen probably more complications of major bleeds following USG guided tapping than clinically doing the tapping, because when they see an ultrasound large pockets of fluid, sometimes complacency creeps in, especially if you have an inexperienced person doing USG guided ascitic fluid tapping. When you have the ascitic fluid report, the first thing that you look for is the serum ascites albumin gradient. And this was a wonderful work done by Bruce Runyon and his group published in Annals of Internal Medicine way back in 1992. Why I'm going back to this paper, and I'll go back to a couple of very old papers to understand the impact that they have had on our thought processes, and very importantly, where do we go wrong because of overemphasis on these papers. So this was a pioneering work where they looked at serum albumin minus ascitic fluid albumin and called it the SAG, serum ascites albumin gradient. And when they looked at patients with cirrhosis, whether they were infected or sterile, the SAG ratio was, the SAG was more than 1.1. And if you looked at cardiac ascites, it was again more than 1.1. And patients with other causes of portal hypertension also had 1.1. And if the patient had ascites because of a non-portal hypertension related cause, then they found that the SAG ratio was less than 1.1. If the patient had mixed ascites, the SAG remained more than 1.1. And this was their patient cohort. A quick thing to see, the number of patients with cirrhosis was 758 with or without infection. That's 84.1% of the cohort. And if you see the local causes were just 42. So based on this 42 patients data, we have till now based our clinical approach towards understanding the etiology of patients with ascites. So this is important for us to know, because there are limitations of the SAG. The SAG can go wrong in patients with ovarian tumors specifically. The SAG can go wrong in patients with severe hyperproteinemia. If your serum albumin levels are very low, the SAG may be low despite the patient having portal hypertension. And we are all aware of the cardiac cirrhosis where the SAG is usually high, and myxedema ascites where the SAG is high. So when we talk of management of ascites, you are looking at the gradient, the grading of ascites, and certain terminologies like tense ascites, refractory ascites, recalcitrant ascites. So what does this mean? So grade 1 ascites is when it is detectable only on ultrasound or on radiology. Grade 2 is moderate ascites. Grade 3 is severe ascites. Tense ascites is a term which was defined based on intra-abdominal pressure, but for us as clinicians, tense ascites means whenever there is a resistance to palpation of organs on percutaneous, on per abdominal examination, when you try to press your fingers in the ascites, that is called as tense ascites. Refractory ascites occurs in around 10% of cirrhotic patients. Once refractory ascites develops, the survival is around 6 months. And within 1 year, the mortality is almost 70%. Now, the refractory ascites is further subdivided into 2 types. The diuretic resistant ascites, which is ascites difficult to mobilize as defined by a failure to lose at least 1.5 kg per week of fluid weight, despite maximal diuretic therapy with spironolactone and furosemide, or an equivalent dose of distal acting and loop acting diuretics. The second term is diuretic intractable ascites, which is difficult to mobilize because of the inability to provide effective doses of diuretics because of diuretic-induced side effects like azotemia, hyponatremia, or other complications. When we come to now the management of ascites itself, the first step is salt restriction, and there's a huge controversy in this itself. Now, when we say salt restriction, what does it mean? The ACLD says sodium restriction to 88 millimoles per day, because 78 is the obligatory renal loss and 10 millimoles is the obligatory non-renal loss of sodium from the body. So it is around 2 grams of salt per day, 2 grams of sodium per day. So this is then, if you go to the EASL guidelines, they talk of moderate restriction of salt intake to 80 to 120 millimoles per day, which corresponds to 4.6 to 6.9 grams of salt per day. The EASL guidelines say that it is equivalent to a no added salt diet. So if you are not taking up pre-prepared meals, that is ready-made meals from the market, if you're making your own food, then a moderate restriction of salt intake is just having the usual salt. Now, unfortunately, this is not true for our Indian population. An average Indian consumes 10.98 grams of salt per day. Now, even in this, there is regional variability, and it has varied from 8 grams to 25 grams. So there are parts of Maharashtra where the average salt intake goes up to 25 grams per day. I'm sure there are other parts of the country where the salt intake is more. So for our patients, we cannot advise them to have no added salt, but just the usual salt. Here we have to actively advise them to restrict their salt intake to around 5 grams. An easy way to do that is 1 small pinch of salt is around 1 grams. So you tell your patients to have around 5 pinches of salt in a day, while ensuring that they don't have any food which has any salt in it. There are certain certain foods which are inherently rich in salt in India, especially like your pickles and papad and those sort of things. One of the mechanisms, one of the recommendations was, if you can make the salt restriction even more severe and come down to 2 grams, 1 grams, or even no salt, you may actually get a better ascites control. But there is a trade-off. If you do a very strict salt restriction, the food actually becomes non-palatable, and this compromises on the nutrition and the patients actually start becoming malnourished because they restrict their intake of food, and this is a huge problem. So if you have an option of having a dry, frail patient versus a wet, robust patient, you would any day choose a wet, robust patient than a dry, frail patient. Water restriction is not routinely required. It should be done only in the presence of dilutional hyponatremia. So if the sodium levels fall below 125 or 120, you will advise water restriction. Otherwise, water restriction is not recommended at all. Now, I would want to tell you about some surreptitious salt intake food items. We all are aware of pickles, rock salt, and black salt, but also all the sauces, soy sauce, barbecue sauce, tomato sauce, have a lot of salt. Seafood, especially prawns and shrimps, are rich in salt. Packaged products like soups, hams, cheese, juices, fish, and poultry have a lot of salt. Bakery products, because they have baking soda, are inherently rich in salt, like bread, sandwiches, pizzas, bagels, pastas, hummus. Your effervescent tablets are effervescent because they contain sodium bicarbonate, and that is why they have a large quantity of sodium. And dried fruit powders. So powders like amchur powder or imli powder, even if the package doesn't mention, once you taste, you realize that a lot of them will have a lot of salt intake, salt content. Next, we come to diuretics. So after salt restriction, almost all the patients you would need to give diuretics. The only patients where salt restriction would work is somebody with a grade 1 ascites. We know that aldosterone antagonists are more effective than loop diuretics and therefore are the diuretics of choice, and all the regimens have to be spironolactone based. However, the question comes whether you should give aldosterone alone, starting with 100 milligrams per day and going up to 400 milligrams, or you start off with a combination of aldosterone and furosemide or a loop diuretic. The disadvantage of aldosterone is that it takes almost 72 hours for its significant action to take place. And our patients are quite impatient, and therefore they are happier if you start them on a combination of spironolactone and furosemide, beginning with 100 milligrams of spironolactone and 40 milligrams of furosemide. It also helps because you get rapid natriuresis as well as the potassium levels are well maintained. In outpatient setting, with patients who have grade 1 or 2 ascites, you may think of starting only spironolactone, but be careful about potassium levels because they can tend to go higher. My experience is a lot of our patients, when they are diagnosed with any major disease, they start drinking a lot of fruit juices. Most of our patients also have slightly lower hemoglobins, and therefore they almost inadvertently will start drinking juices comprising of pomegranate juice or tomato juice, anything that is red, its juice will be consumed, beetroot juice. So that pushes the potassium up, and we have had life-threatening hyperkalemias very commonly because of this approach. So my personal choice for our patients is a combination of furosemide and spironolactone. The doses of both the oral diuretics can be increased simultaneously every 3 to 5 days, maintaining this ratio if the weight loss and natriuresis are inadequate. So how do we assess this response to diuretics? In an outpatient setting, you have to counsel the patient well. Most often, I would call the patients once a week for follow-up till I can get their ascites controlled. Ask them to report early if there are alarm symptoms. So if they feel very fatigued, if they are having reduced urine output, if they have pain in abdomen, if there's features of encephalopathy, then they should come immediately. We also ask them to maintain a blood pressure chart at home if possible. They have daily weight charting, and report us if there's anything alarming there. Reduction of body weight of less than 2 kg per week would lead to increase in the dose or adding a loop diuretic if the patient is only on spironolactone. Once a week, we do creatinine and electrolytes for these patients. And every follow-up, we look for symptoms of fatigue, cramps, and hepatic encephalopathy, especially minimal covert hepatic encephalopathy, because that tends to creep in and go unnoticed. So unless you're looking actively for it, you may miss it, and then the patient will come with frank hepatic encephalopathy. You check the blood pressure, but please also remember to check orthostatic hypotension. A blood pressure drop of more than 20 would mean that the patient is significantly hypovolemic. The effective arterial blood volume is low, and this would entail that you need to reduce the diuretics and correct the volume status of the patient. In an inpatient setting, for grade 3 ascites, you would always start with a combination of a loop diuretic and spironolactone. The maximum recommended weight loss during diuretic therapy is 0.5 kg in patients without edema and 1 kg in patients with edema. Although, if the patient has massive edema in the feet, a greater weight loss than 1 kg is pretty much acceptable. In an indoor setting, you review the dosing every 2 to 3 days. Do not change the dose every day. So this is a word of caution when you're monitoring these patients. Every day, morning, evening, you check the blood pressure and look for orthostatic hypertension. And creatinine and electrolytes are done every alternate day. When do we reduce the dose of diuretics when the patient comes for follow-up? When the patient has had a complete response of edema feet, that is, the ascites is still there, but edema feet has disappeared, you decrease the dose of diuretics. The next time is when the patient has even disappearance of ascites, then you would again reduce the dose of diuretics further. If there is a loss of weight of more than 1 kg in presence of edema feet and 0.5 kg without edema feet, then you would reduce the dose of diuretics to prevent complications. Patients who come to you with postural hypotension, patients with mild elevations of creatinine, 0.1, 0.2, you would want to decrease the dose of diuretics. And if you have potassium levels less than 3.5 or more than 5.5. When will you stop the diuretics completely? Patients who have come with spontaneous bacterial peritonitis, patients with new onset hepatic encephalopathy, patients who have come to you with hypotension, blood pressure is less than 90, then you would stop the diuretics. If the creatinine is increased by more than 0.5, 0.3 over the baseline, if despite being on diuretics, there is a sudden drop in urine output, this patient should not be subjected to increased dose of diuretics. In fact, you should stop diuretics till you know why the urine output has dropped suddenly. In patients who come with GI bleeds and patients with sodium levels below 120 or 125, depending on what school of thought you belong to. The other diuretics which we use, this was a wonderful study done by Paolo Angeli almost 3.5 decades ago, which looked at amiloride and compared it to aldosterone-like drug, which is potassium canrionate, and they found that amiloride was not as effective as spironolactone. Amiloride was very modestly effective, but it was effective in patients who had normal RAS levels. So if the RAS levels are normal, then amiloride is effective. So today, amiloride is used only for patients with spironolactone-induced gynecomastia. The other drug that we now have as an option to amiloride, which is probably more potent, is eplerenone, which is known to reverse spironolactone-induced painful gynecomastia and cirrhotics. Please remember that it takes around 3 months. The equivalent doses of eplerenone is 50 mg of eplerenone is equal to 100 mg of spironolactone. So you have to give half the dose. So it's double the potency. If you look at the non-selective beta blockers, there is again a controversy in patients with severe ascites, whether we should continue or we should not. But there are certain indications where we should discontinue non-selective beta blockers in presence of ascites. One is when the patient has developed SBP. Second, if the patient has a decline in the systolic blood pressure to below 90 millimeters of mercury, if the patient has developed hyponatremia less than 125 millimoles, in patients who have developed acute kidney injury, and if the patient has a pulse rate lower than 55 per minute, then we should stop the beta blockers. Why should we do this? Because there is a risk of increased mortality in patients with SBP or patients who develop SBP while on being beta blockers. So this was a very elegant study which was done some time back, which looked at the risk of hypotension during the first paracentesis if the patient was on beta blockers versus the patient who are not on beta blockers. And here, all the patients who were on non-sedative beta blockers did worse in terms of the mean arterial pressure, the systolic pressure, the need for the first paracentesis, and the first SBP development. All were worse. So in patients with severe ascites with the history of SBP, you have to be very careful with beta blockers. So there was a difference in the transplant-free survival in those patients who had SBP. So in patients who have SBP, one must avoid beta blockers. Of course, in HRS and AKI also, we should be very, very careful while using beta blockers. And like I said, it's best avoided. The next question comes, in patients with severe ascites, can we use IV furosemide? And I'll be talking about the SAFI-CEFIT regimen later on, but here we are just talking about using IV furosemide to induce rapid loss of fluid and rapid control of ascites. So this was a very elegant study almost 3.5 decades ago, because I have had debates with the intensivists very often who tend to use IV furosemide very easily for patients with liver diseases. So this was a study which looked at the effect of intravenous furosemide on renal clearances. Group 2 and 3 were the patients with cirrhosis without and with ascites. This was just a proof of concept study. So what you can clearly see is that there is a patients with ascites showed a very rapid decline in the glomerular function, and the para-aminohypurate clearance was actually much lower within the first 20 minutes, and it kept on worsening for the first 60 minutes. Similarly, insulin clearance also dropped significantly in groups 2 and 3, which are the cirrhotic patients. So the study concluded that IV furosemide in cirrhotic patients actually impairs renal clearances. This is how the GFR actually drops once the IV furosemide is given, and it does not come back to normal even after around 4 hours. In fact, it remains slightly on the lower side even after that. So you may actually paradoxically worsen the renal function in patients with the use of IV furosemide.
Look, Akash, can we take a break for the out here?
Yeah, sure.
Thank you, Akash. Before we move on, we will take some questions. There is a flurry of questions coming. Let's take some questions for next 5 to 6 minutes, then move on. This first question is from Anand Gupta, Jaipur. He says that EASL guidelines recommend paracentesis for new onset grade 2 and 3 ascites. Does this mean that new onset grade 1 ascites need not be tapped?
I think we would always tap if the fluid is tappable. If the only patients where you need not tap is if it's a very small interbowel fluid which is practically non-tappable. Some patients with grade 1 ascites you can ignore tapping, but I think for almost all patients who have significant ascites, you would do a tap.
Okay. Next question is from Shivram Prasad, Vishakhapatnam. He asks, in the pathogenesis of ascites, how much is the contribution of low serum albumin? Is there any threshold above which cirrhotic ascites is unlikely?
So I think it does play a role, but and definitely we know that it reduces the plasma oncotic pressure, but it is not the main pathogenetic mechanism. If you ask for a particular level, to me, whenever I see a serum albumin level of 3.5 or above unsupported, this patient has not received albumin, I would definitely look for other causes of ascites before I attribute it to cirrhosis.
Okay. And there are a lot of questions regarding ADA, utility of ADA. So one question is from Nikhilesh. ADA is not reliable. So is there a role of TB PCR? Another question, is there any ADA cutoff for use in cirrhotic patients with tuberculosis? And another question on ADA, can we lower the cutoff of ascitic fluid ADA to help diagnosis of TB in cirrhosis?
So I think we have had, I think, quite a few studies on this from the major institutes, and we found that it was useful for patients with who had pure tuberculous ascites and pure cirrhotic ascites. The problem is very often we are dealing with patients with mixed ascites, and there the performance of ADA actually becomes unreliable, and therefore we look for alternative techniques. Unfortunately, investigations like TB-PCR have even lower sensitivity, and therefore would almost never come positive. We have tried doing gene experts, and that also is almost always negative. So the only thing which helps whenever you are in a dilemma, whether you are dealing with TB or not, is either an imaging showing tuberculosis elsewhere, especially if you have pulmonary lesions which are or sputum positivity, or if you see on the peritoneum classical features of tuberculosis, or you do a diagnostic laparoscopy, and in that you do a peritoneal biopsy and you show that the patient has peritoneal tuberculosis.
Okay.
While worrying about the cutoff of ADA, I don't think there is robust data enough for us to suggest a cutoff value that below this you can safely rule out TB.
Yeah, there is one suggestion from Dr. Philip Abraham. He says that one more indication for ascitic tap can be unexplained diarrhea in a cirrhotic patient with ascites. What do you say about
that? I would agree with that. Completely agree. That's again one of the features of SBP.
one other question about scleroderma associated ascites with normal cardiac status and normal liver. Any idea?
So we have had one patient who had scleroderma and he came with ascites. We have seen this in patients with MCTD also. So we don't know what is the mechanism, whether it is because of the fibrosis in the peritoneum, because we did do laparoscopy in this patient and we obtained biopsies also. Unfortunately for us, the peritoneal biopsy was normal. So we did liver biopsy, we did peritoneal biopsy, both came normal. So these are my experience of two patients. And Dr. Manoj, you can add if you have.
No, that's okay. There are many more questions, but I think I will take one more question. From Rajendra Patel, in the era of increasing medico-legal cases, should all diagnostic typing be done under USG guidance? That is an important medico-legal question.
Very important question. I think there is enough data in literature to say that there is no increased risk of complication in patients who have significant ascites. You know, if you can percuss the ascites, you can safely do ascitic fluid tapping. When you can't percuss ascites, or it's a small quantity ascites, or clinically you can't get the shifting dullness, that means there is a possibility that it could be a loculated ascites, or in imaging has shown that there is a loculated ascites, then it is better to go for USG guided tapping. But for routine significant ascites, which is percussible, you can demonstrate shifting dullness, I don't think even medico-legally it is. There's some practice by a small a proportion of people and not everybody. It is still acceptable. So this is an acceptable technique, and therefore, according to Boulogne law, you are to use it.
Rest of the questions at the end of the lecture. Maybe we can move on with your lecture, Dr. Akash.
So next we come to should we give the albumin intermittently? This was a beautiful study, multicentric from again the Italian investigators, the ANSWER trial, which showed a significant improvement in the overall survival. This was the Kaplan-Meier estimate. Over 18 months, there was an improvement in survival. When they looked at cumulative incidence of death and TIPS or liver transplantation, patients who were on the intermittent human albumin group did better in terms of both survival as well as need for TIPS or transplant. This was across the child pug score, and even there was an improvement in the MELD score for these patients. This was on the basis of competing risk model, and they looked at the need for first paracentesis. That was also lower in patients who were on albumin, and the risk of development of refractory ascites was also significantly lower. So the hazard ratios were 0.48 and 0.43 if the patients were on weekly albumin therapy, and this was competing risk analysis. So that is what makes it even more robust data, not just Kaplan-Meier. When they looked at the complications, the risk of SBP, the non-SBP bacterial infection was lower. The risk of development of hepatic encephalopathy, renal dysfunction, hyponatremia, HRS, hyperkalemia were all lower when patients were treated with albumin therapy. Of course, the portal hypertension related complications were similar in the two groups, and that is what you can expect. So coming to the next part of the talk, management of refractory ascites. Now, if you have exhausted your diuretics, which is what the definition says, that if you have given the maximum dose of diuretics, 400 milligrams of spironolactone or 160 milligrams of furosemide, or patient develops complications because of the diuretics, then you call it refractory ascites. But before you label somebody as refractory ascites, please go through this checklist. And this is the most important step. This is where very often you'll find a reason for the refractory ascites. And if you correct this reason, you will correct the refractoriness of the ascites. So the first thing is to look for salt compliance. You look at the history of the patient. Very often ask the family members, if they're daughters, wives, please ask them. You look at the urine spot sodium to potassium ratio. Now we have given up on doing urinary spot sodium, but if you look at urine spot sodium to potassium and somebody has a weight gain despite having a high sodium to potassium ratio, then you know that the compliance is a problem. Look at the dose of diuretics, whether the appropriate dose of diuretics is going on, whether the patient has been taking what we have prescribed or not. Third is look for hypovolemia. Look for postural drop, IVC, skin turgor. Very often you have not asked the patient to restrict their water intake, but somebody in the family or some other doctor or family physician has advised them not to drink water. And in the summers, he is still drinking 1 liter of water. And that is what is causing hypovolemia, AKI, and that is what is leading to refractoriness of the ascites. Rule out vascular issues. So always do a Doppler, and if required, if the creatinine permits, then do a cross-sectional imaging to rule out portal vein thrombosis, hepatic vein thrombosis, or even portal arteriovascular fistulae. Take a history for drugs like NSAIDs. Very often patients don't even count NSAIDs as drugs. Also look for history of methotrexate, amiodarone. Ask them if they're taking alcohol. Very often they're taking small quantities of alcohol, and that is what makes the ascites refractory. I would always do a 2D echo to rule out a cardiac disorder, especially either a primary cardiac disease in alcoholics, dilated cardiomyopathy, or patients with severe cirrhotic cardiomyopathy, which may be contributing to the ascites formation and making the ascites refractory. Beta blockers need to be stopped once the patient has developed diuretic refractory ascites, and I would always do that to see if the cardiac function improves, the cardiac output improves, and we actually have better renal perfusion, and the patient actually starts losing the fluid. And I would always rule out infections, tuberculosis infections, SBP, or infection elsewhere in the body before we label somebody as refractory ascites. So ascitic fluid tapping at this stage is mandatory to ensure that we are not missing out on a peritoneal infection. The first step is often large volume paracentesis. It is the most common treatment for refractory ascites and is defined as aspiration of more than 5 liters of ascites. It does immediately relieve ascites and tenseness, but the ascites will almost always recur and does not improve the survival. It only makes the patient comfortable. So the indication today is if the patient has having respiratory embarrassment or the patient is unable to carry out his activities because of the ascites, that is when you would advise large volume paracentesis for immediate relief. The risk is development of paracentesis induced circulatory dysfunction, and I'll talk about that in a moment. The other thing is even when we are doing LVPs, we must continue the diuretics if the patient is tolerating them, unless there are major complications or the urinary sodium level is less than 30 millimoles per day. So this is one of the situations where urinary sodium level is still having a role. So what does LVP do? LVP basically increases the synthesis of NO. This reduces the systemic vascular resistance, decreases the mean arterial pressure, which is also reduced because of the reduced intra-abdominal pressure, causing hypovolemia. This reduces the cardiac index, pulmonary pressures, and gives rise to activation of the renin-angiotensin-aldosterone axis. It does stimulate the cardiac volume receptors because of the sudden volume loss, stimulates the atrial natriuretic peptide, thereby causing the increased vasodilatation, contributing further to hypovolemia. So all these together contribute to the development of PICD. So Perigenes is my teacher and under whom I trained, did this excellent study way back in 1988 to see whether giving intravenous albumin after paracentesis helped or not. And what they showed was that in patients in group 1, which is the one which received the albumin therapy, there was no drop in the BUN and the sodium levels, unlike the control arm, as well as the plasma renin activity and the plasma aldosterone concentration did not differ 5 days after the tapping in those who got albumin as compared to those who did not. When they looked at the other complications, overall complications were similar in the two groups, but there was no hyponatremia or renal impairment in patients with who received albumin. Only one patient developed hyponatremia as compared to 9 and 6 patients in those who did not get albumin. Now, this was a meta-analysis of multiple trials, and as compared to all other volume expanders, albumin did much better with a hazard ratio of 0.34, odds ratio of 0.34. So with a 95% CI of 0.23 to 0.51. So very, very strong evidence in favor of albumin. The evidence of albumin as compared to vasoconstrictors is more weak. The meta-analysis did not show a huge difference, although there was a tendency towards favoring albumin, but it did not reach statistical significance, and the two were found to be comparable. Similarly, mortality was significantly different if you used other volume expanders as compared to albumin. So you must use albumin. It saves lives after doing a large volume paracentesis. With vasoconstrictors, again, the mortality rate was similar, although there was a tendency towards favoring albumin. So to prevent this PICD, albumin is given in the dose of 8 grams per liter of fluid removed. The most important thing in this is this has to be done after the tapping is over. So start the albumin infusion after the tapping is done. If you don't want to go into the calculations, the simple way to remember is 1 bottle of albumin for every 2.5 liters of fluid that is tapped. That is 20% of 100 ml albumin. Another practice pearls I can give you is do not give the diuretics on the day of tapping and the next day, and do not give beta blockers on the day of tapping. Avoid tapping more than 5 to 6 liters if you can, unless the patient has such a massive ascites that it is mandatory 5 to 6 liters. It does not help the respiratory embarrassment, then you can tap more, but avoid tapping more than 5 to 6 liters. Midodrine was found to be equally effective in one study, and that may be an alternative in case you are not able to get albumin, which is what happened to some of my patients during this lockdown. They could not get albumin, and therefore I had to use midroutine for some of my patients. TIPS is actually superior to large volume paracentesis for long-term control of ascites. And the guidelines say that if the patient has required 4 or more paracentesis procedures, then TIPS is recommended. The advantage of TIPS is it decompresses the hepatic sinusoids as well. So not only improves the circulation, but also decompresses the sinusoids, and therefore it relieves the refractory ascites by directly reducing portal venous pressure. We know that it may improve survival, but it does not reverse the pathological process of the liver cirrhosis, and therefore anybody who needs a TIPS also needs a liver transplantation. So once a patient has reached the stage of refractory ascites, he needs a transplant as soon as possible. So what are the indications and contraindications of TIPS for refractory ascites? Patients who have received 4 or more paracentesis procedures, or if the patient can't tolerate paracentesis or it is contraindicated, then TIPS is recommended. The contraindications are patients with severe liver cell failure, Child-Pugh C13 or above, MELD of more than 20, patients with cardiac failure, in particular right-sided cardiac failure, patients with pulmonary hypertension. Moderate to severe pulmonary hypertension would entail contraindication to doing TIPS. Similarly, for cardiac failure, yes, even mild to moderate right-sided cardiac failure would mean that you cannot go ahead with TIPS. This does not mean that left-sided cardiac failure you can go ahead. That is an obvious contraindication. Patients with anatomical or technical contraindications, unrelieved biliary obstruction, and extensive hepatic malignancy is a contraindication for doing a TIPS. What does TIPS do? Why we are talking about TIPS so much? It does improve the urinary sodium excretion, and these are the different studies. And as the time progresses, the urinary excretion actually keeps on increasing, and the serum creatinine actually keeps on decreasing over a period of 4 to 6 months after doing a TIPS. That is because of the improved hemodynamics, as well as because the plasma renin activity will keep on decreasing, the aldosterone levels fall down, and the noradrenaline levels also decrease after doing a TIPS. The cardiac output actually increases. The peripheral resistance decreases after doing a TIPS. And that is why you'll see patients developing mild edema feet after doing TIPS. Not an unusual thing. Their ascites disappears, but some of them will develop peripheral edema, which you can notice on day 2, day 3. And then that persists for almost a month or so, and then disappears because the peripheral the systemic peripheral resistance comes back to its baseline level. Now, what is the effect of TIPS on nutrition? It is associated with improvement in the body cell mass, in the muscle cell mass, and increase in the caloric intake, as well as the restricting energy expenditure. So improved nutritional status is an important finding. Recent studies have also shown that it is associated with increase in the sarcopenia, as well as the performance status. Does it give survival benefit? The initial studies were mixed, with some studies showing survival benefit and some not. But now we know for sure that most patients actually have a chance of improved survival with TIPS as compared to with just large volume paracentesis. So there is some survival benefit with TIPS. One of the concerns which people have is if you have done a TIPS, then doing transplant is difficult. This was a very elegant study published in Hepatology in 2016 from the US database, and which looked at over 7,000 patients who had undergone TIPS, and they showed that the risk of death or transplantation was lower for patients who have undergone a TIPS. So their survival was better, and even they had a better chance of undergoing a transplantation over a period of time. So their survival till transplantation was better. So less people died, and a greater proportion of patients survived till transplantation. So the waitlist mortality was lower in patients who had undergone TIPS, and patients could be successfully transplanted. So you need not worry about the TIPS for transplant as long as the TIPS is appropriately placed. The problem is if the TIPS stent is projecting way up into the right atrium or projecting way down into the extrahepatic part of the portal vein, then you will struggle at the time of transplantation. So the appropriate length and the right placement of the TIPS stent is of paramount importance. Coming to the last part of my talks, and that is vasoconstrictive drugs. Midodrine and clonidine are the two vasoconstrictive drugs. Midodrine is used in patients with cirrhosis and ascites. It increases the effective arterial blood volume by causing splanchnic vasoconstriction, improving renal perfusion and the glomerular filtration. And therefore, the ASLD guidelines recommend midodrine for refractory ascites. The other drug is clonidine, which is an alpha-2 adrenergic agonist with effects that are similar to midodrine. So it increases the, causes vasoconstriction. But the advantage of clonidine is that it reduces the blood pressure. So in most of the patients, it is not useful. But it is the only drug which you can use in that subgroup of patients who come to you with very high sympathetic nervous system activity and therefore have tachycardia and hypertension. So a very small subgroup of patients, especially young patients, young cirrhotics in their 30s and 40s, it is not unusual to find having, some of them having a blood pressure of 160, 170, 180 systolic, and that is where you struggle to control their ascites. Their renal function is very brittle, and there you can use clonidine effectively. Midodrine, of course, helps because it increases the blood pressure. Now, use of midodrine in refractory ascites was shown in several studies, including by Professor Virendra Singh from PGI Chandigarh. We know that it improves the weight as compared to standard medical therapy because of reduction in the ascitic fluid. It increases the mean arterial pressure because of splanchnic vasoconstriction, and increases the urinary volume because of the improved renal perfusion. So this is was shown in several studies. In another study, they demonstrated that the sodium excretion in the urine improved, the plasma renin activity reduced, and the plasma aldosterone levels also fell down at 1 month after using midodrine. So we know it inhibits the renin-angiotensin and aldosterone axis. It will cause peripheral vasoconstriction, improves renal perfusion. The thing is, it does not always translate equally into the benefit in clinical practice. Can't expect magical outcomes. So yes, we know that the response rates improve complete response is far more common in patients with midodrine in refractory ascites as compared to standard medical therapy. Partial response is pretty common. So this was a study which looked at 3 months and 6 months. So at 3 months, partial response was present in 10 patients as compared to 7 patients in the standard medical therapy group. But more importantly, there was no response in only one patient of midodrine and 8 patients of medical therapy. So you can expect some partial improvement at least in a majority of patients, and complete improvement in almost a third of the patients who are treated with midodrine. The key thing is dosing of midodrine. The starting dose is 5 milligrams orally 3 times a day, and you adjust the dose frequently to achieve an increase in the systolic blood pressure of approximately 10 to 15 millimeters of mercury, or more likely, after a very elegant study, we know that if you have achieved a target mean arterial pressure of 82, then it is associated with much better control of ascites and less renal dysfunction. Midodrine should be taken during the daytime only to prevent risk of supine hypertension, and there should be a gap of at least 6 hours between the 2 doses. The drug interactions of midodrine have to be remembered. You cannot combine it with digoxin. You cannot combine with other drugs which increase blood pressure like phenylephrine, ephedrine, thyroid hormones, ergot derivatives, or salt-retaining steroids like fludrocortisone. You can't give it with MAO inhibitors. If you give it with alpha blockers, then you can antagonize the effects. So patients with prostatic enlargement, you have to be very, very careful because midodrine can cause urinary retention, and therefore do not use midodrine in these patients. Interaction with metformin, ranitidine, and other antiarrhythmic drugs is also there. So we have to be cautious about using. Then we come to Veptans, which are V2 receptor antagonists. They are very, very tempting to use because of the aqueresis, that is loss of just water without loss of sodium. And therefore, we are all tempted to use it in patients with dilutional hyponatremia, because you can treat hyponatremia as well as reduce the fluid overload, because these are the patients where you cannot right now use diuretics. The only thing that you can do is restrict their fluid intake and wait for the sodium to correct. Very often it takes a long time for the sodium to correct in these patients. So the initial reports were promising, but then a negative phase 3 study with cetabaptan was a major setback. And then of course the black box warning, which came, which sort of nailed the coffin for Veptans. So the risks and the cost did not entail the routine use of Veptans. In fact, the guidelines mentioned that there is no evidence that we should use them. The risk is too high in 2012. But there is a renewed interest in these Veptans because of our better understanding and the right indications. And these are the 3 studies which showed that there may actually be a role for tolvaptan in patients with refractory ascites. So the first was a Japanese study in J Gastroenterology, where they looked at the subgroup analysis of patients who benefited with tolvaptan, and these were the patients with severe hyponatremia. So edema with severe hyponatremia. Then the second study showed that in patients with normal renal function only, there is a benefit, and but even those patients who have impaired renal function may also get some benefit with the use of tolvaptan. So this was a study published in BMC Gastroenterology in 2018, which showed that overall patients who received tolvaptan, they actually benefited in terms of survival. And when they looked at the subgroups, it was patients who responded to tolvaptan where the sodium levels normalized. They are the patients who had a high chances of survival, as compared to those patients where, despite taking tolvaptan, the sodium levels did not improve. In those patients where hyponatremia improved with a placebo, their survival was still poorer. So this tells us that it was tolvaptan which made the patient survive longer and not just the correction of hyponatremia. But they come with a black box warning. So there is a risk of increased GI bleeding in patients with liver diseases. The otherwise safety profile is good. We have seen some patients developing very large quantity of urine after giving small doses. So we actually start with a much lower dose of tolvaptan, sometimes half a tablet or even 1/4 tablet. But again, remember that this is off-label prescription. This is not something which should be done routinely. The recommendation is that tolvaptan or Veptans should be used only as an inpatient under supervision after explaining the risk to the patient of GI bleeding. In patients with child C cirrhosis, it is best avoided. It has also been shown to be associated with intracranial bleeds as well. The sodium levels should be monitored very closely, because if you are not careful, the sodium levels can go up dramatically, and that can cause osmotic demyelination. What about combining the two, midodrine and tolvaptan? This was an elegant study done by, again, Professor Virendra Singh, and he showed that the combination of tolvaptan plus midodrine plus standard medical therapy led to more complete responses as compared to either tolvaptan or midodrine. We have a new device called as Alpha Pump System. This is a new technology that was introduced only around 3-4 years ago. It is a subcutaneously implanted battery-powered patient, which takes the ascites from the peritoneal cavity and puts it into the urinary bladder. It is useful for patients who are unsuitable for TIPS or who have failed TIPS, or patients with portal vein thrombosis which was not amenable to TIPS, or patients with severe cardiac dysfunction associated. So where nothing else works, and the moment you give diuretics, their creatinine starts going up. So those are the patients who do well with such alpha pump placement. It reduces the need for LVP, but it is a potential source of infection. Availability in India is still an issue, and cost is prohibitive. It costs almost up to 20 lakh of rupees if you want to put it. So I have had only one patient who actually had it inserted in France and then came to us because he shifted to Mumbai. Plurex may be an alternative, but again, this is just case reports which we have, and we don't have any proper study.
Akash,
Now, Steph,
yes, Akash will have to bind up.
Yeah, there's the last two slides. So, Cephet, Dr. Professor Vivek Saraswat is the one who, along with Gaurav Pandey, had talked about Cefi and Cephet, which is continuous infusion of furosemide albumin with monitoring of urinary sodium, along with hemodynamic monitoring and potassium monitoring, and adding terlipressin if the urinary sodium remains low. And they have shown excellent results with this CFAT. This is how they monitor. Of course, there are stopping rules. We need validation from other centers. Liver transplantation is the treatment of choice for patients with refractory ascites, and this is associated with radical reversal of portal hypertension and excellent survival after the transplantation. So, coming to the final steps, to summarize, we start with salt restriction as the first step for control of ascites. Then we initiate diuretics. We monitor the weight, creatinine, electrolytes, look for clinical features like postural hypotension. Increase the dose of diuretics if the above parameters are good. But at this stage, when the increased requirement of diuretics is there, counsel the patients about the need for transplant in the near future. If the patient still develops ascites further, consider adding regular albumin infusions. Despite this, if the ascites progresses, checklist for all the causes of refractory ascites and correct whatever we can, especially recheck the salt compliance. This is the time to consider doing a liver transplant because we are now labeling this patient as refractory ascites. The options that you have is LVP with adequate albumin replacement. If it is done repeatedly, then it is better to do TIPS if there are no contraindication to doing TIPS. If TIPS is contraindicated or patient is unwilling, then add midodrine, especially if the mean arterial pressure is low or the patient has a brittle renal function and is sensitive to the diuretics. If the patient has hypovolemic hyponatremia and is not a child pug C, that is his child pug A or B, you can give tolvaptan with due risk as an acute measure to get ascites and sodium under control under close supervision. Repeated taps is the last resort if nothing else works. In such patients, you can explore alpha pump or other research protocols. Thank you very much for a patient hearing.
You have some questions?
Yeah, I can ask a question.
Okay. One question you can ask.
Which of the following statements is true? Non-selective beta blockers need to be stopped if patient develops new onset ascites. TIPS is safe in patients with moderate pulmonary hypertension. Rock salt can be consumed in cirrhotic ascites. And option 4, tolvaptan has a high risk of IC bleed in advanced cirrhosis.
Right. I think while we wait for the audience, please keep the question on your screen, Akash.
Yeah.
Maybe we can start with some of the questions that have poured in for your talk. I think we'll probably, because of time constraints, stick with just this one question and skip the other two that you might have got ready, Akash. So I think I must compliment you on a very detailed and a very informative talk on ascites. It's a huge topic and there are a lot of practical this step-by-step approach, I'm sure people have come to learn a lot. But I think because what I'll do is in the next about 7-8 minutes, put some of the questions that have come in from the audience. And I think whenever you are ready with the answer, Govind, please do step in. So I think the first set of questions, I'll start with the early part of your talk, Akash, were to do with the procedure of ascitic tapping. How would you consider tapping or sampling a patient who is on chronic ambulatory peritoneal dialysis? Because they always have an indwelling catheter, and how do you diagnose SBP in this situation?
So I think patients who have an indwelling catheter, you don't really need to tap. What we usually will do is we would, if you are suspecting an infection, we would culture them, because some amount of elevation of WBCs is common in patients who have a peritoneal catheter. So if the WBC count is in thousands, or if the culture is positive, then we know that there is an infection. I would not use the word SBP in patients who are on peritoneal dialysis, because it will be virtually impossible to say whether it is primary or secondary, because you have a known source of infection in these patients.
So you just call it peritoneal fluid infection. If
Yes,
you pick up, and the criteria for that would be the same as 250 polymorphs, or
no, it's usually when it is more than 1,000, that is when we usually will say. But its culture has to be positive.
Right. I think we spoke a bit about mixed ascites, and that's quite common. So what are the precise diagnostic criteria you would use to label a patient as having? This is Dr. Ankit from Mumbai who wants to know.
So I think one of the, if the patient has both portal hypertension related ascites and tuberculosis, you have to have a high SAG ascites, that is for sure. In addition, you need to demonstrate tuberculosis in some form. So either a ADA value which is very high, or a radiological feature which is consistent with tuberculosis, or a sputum or extraperitoneal tuberculosis proof in the form of sputum AFP, or a diagnostic laparoscopy showing a peritoneal biopsy caseating granulomas or tuberculosis. So I think we need one of these to be sure that we are dealing with a combination of portal hypertension, ascites, and tuberculosis.
Right. So, and in the same continuation, Doctor from Chennai has, I think probably this question has come up earlier, that what should be the cutoff of ADA for diagnosing tuberculosis in cirrhotic ascites given the low protein values? And in fact, Professor Philip Abraham has suggested that maybe 25 or lower, maybe rather than the usual 37 or 40, could be the cutoff in cirrhosis. So, what are your comments on that?
So I think we don't have a systematic study to or robust enough data to have a definite cutoff value. Although there are studies which have proposed lowering the criteria, but it will also depend on the stage of cirrhosis. Somebody has a protein, ascitic fluid proteins of 0.03 or 0.1. These patients have a very dilute ascites. Their ADA levels are really, really low. I've seen patients with tuberculosis with ADA values in single digits also. So I won't commit to a particular level as the cutoff. You have to use your clinical discretion in these patients, and you have to have a high index of suspicion. That's the key thing. And very often I've seen patients with patients with peritoneal tuberculosis also have involvement of the liver very often, and you'll find elevated GGT unexplained in these patients, and that is an indirect indicator.
That is the concomitant other collateral evidence. Regarding the fluid AD value, you are not comfortable with simply lowering it to a certain level.
Giving an absolute lower cutoff value.
Okay. Any answers, Govind? Are you waiting?
Yeah, Dr. Govind Makaria can answer, because I know he has done a lot of work on this.
No, so we have answer to the question which the poll for audience. Say 87% people say tolvaptan has a high risk of IC bleeding. 30% non-selective beta blockers need to be stopped, and likewise. So any comment on that, Ascites?
So I think most of them have got it correctly, that tolvaptan has a high risk of bleeding. They were listening to the talk because this was not in the slides. I had only spoken this sentence. So thank you, audience. And I think amazing. They've really made my day.
we've
So
had a
perfect.
very good audience participation today.
So can you stop sharing your screen, Akash, so we go to real panel? Yeah. Okay.
All right. So I think maybe another 5 minutes of questions, Govind?
Yes, sir. Yes, sir.
Right. So Dr. Anand from Chennai wanted to know from you, Akash, about the differentiation between hemorrhagic ascites and a traumatic TAP. And what exactly in a cirrhotic patient significance do you attach to hemorrhagic ascites? All very simple and practical questions, but it would be nice to hear your view on this.
Yeah, I know. So this is a very practical question. So traumatic ascites usually will with the blood clots when you keep it, and it is because of the needle trauma that there is bleeding, and because this is fresh blood, therefore it clots. Hemorrhagic ascites, on the other hand, is already had a bleeding and has lysed, and now you are seeing the RBC, so that does not clot again. So that is how you differentiate. So you just keep the sample for 5-7 minutes in front of you, and you see whether the clot forms or not. The importance of hemorrhagic ascites is that you should immediately suspect whether you're dealing with a malignancy. And to me, so malignancy or a or a pancreatitis, necrotizing pancreatitis along with it. So these are the two conditions which I would immediately think of in patients with hemorrhagic ascites. A word of caution here: those who have had previously traumatic ascites, tapping, in them, when you tap next time, you may actually get hemorrhagic ascites. So don't get flummoxed.
Some time for that to clear up. So within a few days apart, you might find that it appears. Okay. And Dr. Shrikant from Delhi wants to know what is the method for therapeutic tapping when you do large volumes. Most often you see people stick in a needle in the abdomen and drain it with a IV set, or should a pigtail catheter and a sealed system be used?
So I think there is one paper which is recently published with the pigtail, but I think most of us who are happy with the needle set, we would put in a 21 gauge needle, put it in the left lower quadrant, and place it in such a way that the traction is still maintained, the pressure is still maintained. I think the key here is the way you fix it. Very often, when you're at the beginning of your career, you're tapping, you only drain 2-3 liters, and the fluid stops after that because the needle has popped out. So it's the way you fix the needle to the abdomen which determines. So that has to be done in a way that traction is maintained even when the fluid is decreasing.
Right. A few questions regarding the SAG value, the serum ascites albumin gradient. Dr. Neha from Gurgaon is asking then what is the serum albumin level below which you would regard this as unreliable? There may be severe levels of hypoalbuminemia, and you actually have a high SAG, but the number is below 1.1.
So in the original study, the lowest albumin value, serum albumin value, was 1.8. So and most of the other subsequent studies have also had albumin levels of more than of 2 or above. So to me, a value of less than 1.8 is something where I'm extremely cautious about interpreting SAG values.
Once serum albumin is below 1.8, you have to be cautious and then use probably your clinical sense rather than simply the number. Right. Similarly, I think Dr. Jayanti from Chennai wants to know what is the utility and what should be the SAG values in patients with myxedema ascites, nephrogenic ascites. Does 1.1 still hold true in these situations?
So absolutely, madam. So both these conditions that she mentioned, the SAG value is actually more than 1.1, and that is the limitation of SAG.
Okay, right. So people are listening to your talk and noting all the points. So, and how reliable is SAG in a patient with mixed ascites when you have a high SAG because of portal hypertension, but high protein because of tuberculosis?
So I think we have had this situation rarely where we had a mixed ascites and the SAG was low. I can count these patients on my fingers. So I think in mixed ascites, almost always the SAG will be more than 1.1. In fact, if you get a SAG of less than 1.1, you will really question how much is the contribution of portal hypertension to this ascites.
Right. Okay. Now, I think you mentioned regarding TEG before tapping in people with cirrhosis and coagulopathy. So there are a few questions about this. Dr. Pradeep Agarwal from Dehradun wants to know that should TEG be routinely used in patients with a coagulopathy? And Dr. Anand from Mumbai is asking, how do you interpret TEG before tapping? If you get a TEG value, and what do you do with it?
So I don't do TEG for every patient. I think TEG should be reserved for those patients where there is a clinical suspicion of either chronic DIC or fibrinolysis, or the patient is septic and with grossly deranged coagulation parameters. So in those patients only I would do. And again, what I'm worried about is the mean amplitude and the LY30. So if I see accelerated fibrinolysis, or I see just a flat curve, what we call as a champagne glass. If you see those sort of curves, then you're worried. If there are a lot of endogenous heparinoids, then you'll be worried, because when you get a flat line. So those are the situations when you're worried. I'm not so worried about the angle or the other parameters.
Okay. And Dr. Akash from Chandigarh wants to know whether measuring D dimers in the blood would be as useful as TEG to identify hyperfibrinolysis. That is your concern?
So I am not aware of a study where they have correlated D-dimer with acidic fluid tapping. So at this stage, even if I do, I don't know how to interpret that data. But that is something which I think should be explored.
Okay, right. And does Dr. Karthik Narayan Chennai, his question is, how do you use the TEG tracing to decide what kind of plasma or component you should give before you do a tap?
Okay. So again, so you look at the platelet component, and so what again I'm interested more is the platelets. So if I have a very prolonged R time, or the MA is really small, that is when I'm looking for using platelets. If I have accelerated thrombolysis, then I would give something like tranexamic acid and allow the TEG to become normal, and then only go ahead and do the tapping for these patients.
Right. I think I'll take a few more minutes. So there are a few questions on diuretics. You've basically given 2 or 3 talks in one, Akash. So standard diuretic management of ascites, cirrhotic ascites, and refractory ascites. I don't think we'll have enough time to cover ground for all of those. About 135 odd questions have come in. So the rest will find their way to your inbox for your reply and putting on the site. So I'll just cover the bit on diuretics now. Dr. Bhavik Shah from Calcutta and Dr. Arun Singh from Indore wanted to know about dose of diuretics that you've used. For refractory ascites, the 400 plus 160, how often or if ever have you used such a high dose of diuretics? Because most people don't tolerate, cirrhotics don't tolerate much above 100 milligrams spironolactone on 40 milligrams furosemide for any length of time.
So I agree that a large proportion of patients will not tolerate these doses. And I think maybe less than, I can't give you a figure, but I think less than a quarter of the patients, or maybe even lesser than that, would actually go on to receive these doses. So I can again remember the patients, probably once a year I see a patient where I go to these doses, not more than that.
By and large, I think we often have side effects kicking in before you can reach these levels. Dr. Rakesh from Lucknow wants to know your thoughts about starting diuretics in ascites in a patient with CKD, and also the use of diuretics when SBP has been diagnosed, stopping diuretics and thereafter mobilizing people. How do you proceed?
I think they're excellent question. So in patients with CKD, the loop diuretics are actually the ones which are preferred because of the risk of hyperkalemia. So unless the patient has a CKD, which is like a salt wasting nephropathy, in which case you anyways won't see ascites at all because there is no sodium retention. So by and large, you are okay to start off loop diuretics for patients with CKD, although these are the patients where you will find it most difficult to control ascites. That is our experience. This combination where patient otherwise is child A and means except for ascites, other parameters are okay. And he has got CKD stage 3 or 4. These are the patients when they develop ascites, it is very, very difficult. And it's very difficult to justify doing a simultaneous liver kidney transplant also for them. So I agree with him that this is the most difficult group. If the patient is on dialysis, then the first step is you rule out other causes of ascites. I think that is very important. Very often you'll have tuberculosis or hypothyroidism related ascites. But intensification of dialysis is a good option for those patients who are on dialysis. You have to fight with your nephrologist to do that, but you can.
Okay, right. There are 2 or 3 questions by Kapil Dhingra from Jaipur, Doctor from Chennai, Dr. Rajendra Pal from Mangalore regarding the management of cramps in a cirrhotic patient with ascites who's on diuretics. It's not an uncommon experience. And what do you do in these situations?
So there are 2 reasons. One is because of electrolyte imbalances, and second is because of the hypovolemia itself, the tissue dehydration. So I think the first step is if there are electrolyte imbalances, you correct them. Especially magnesium and potassium is what you need to correct in addition to sodium, which almost always you would pick up. But if that does not work, then you have to actually reduce the dose of diuretics. And my experience is a lot of time it is because the patient has consciously decreased the fluid intake when you have not advised. So you allow them to listen to their thirst and drink accordingly, and that helps a lot of these patients, especially if they can just have a glass of, half a glass of water just before they go to sleep. That sometimes solves the problem of nighttime cramps.
Okay, right. Very useful practical tips. You mentioned Aplirenon for gynecomastia. So is it available in India, and if so, under what brand name and cost, etc.? Is Dr. Anand Gupta's question from Jaipur.
So it is available in India. Unfortunately, I don't think I'll take the brand names in a public forum, but it's easily available. The nephrologists are using it very frequently. The equivalent dose is what you need to remember. It's twice as potent as spironolactone. So your dose should be half of that what you were using for spironolactone.
For spironolactone. Dr. Rajendra Pal, Mangalore again. Between torsemide and furosemide, any preferences? How often do you have to change from furosemide to torsemide?
So I think there is no literature to show the benefit of one over the other or superiority of torsemide over furosemide. So I have not very frequently changed from one to the other. The only benefit which at times I feel I get is because of the more prolonged action of torsemide. You can get a more sustained effect. That's the only thing. But I really don't see a reason for me to switching over from one to the other.
Right. Bhavik Shah, Calcutta, he wants to know, and it's an important question, during follow-up, how do you approach the question of stopping diuretics? You put a patient with ascites on therapy, ascites is mobilized, now there is nothing on ultrasound, no fluid. How do you go about, would you stop, and how do you monitor these people?
So the patients where I think of stopping the diuretics completely is those patients where the liver function has also improved simultaneously. So alcoholics, patients with hepatitis B, patients with hepatitis C, in the blood care when you have done tips. So these are the patients where the liver function has improved. So you would attempt to definitely stop. If the liver function has not improved, then even if the ascites has become dried completely, I would usually maintain them on very small dose of diuretics. But try to definitely come down to the minimum possible dose in everybody.
Okay, so I think last 2 questions. Dr. Chinta Mori from Rajkot wants to know, once a patient has recovered from diuretic-induced AKI, how do you go about reintroducing diuretics in these people?
I think excellent question. So the first thing which you have to ensure is that patient is really euvolemic before you restart the diuretics. No postural hypotension. And means there are no guidelines on this, but what I usually do is I start off with a lower dose of diuretics than what I was using previously. Usually it is half the dose. And then this time the escalation is much more slower. And if it was there was an additional cause for the AKI, then I do tend to go back to the original dose. But if the cause for AKI was not there except for diuretics, then I would almost never go to the same dose again unless the liver function improves.
Okay. And finally, how do you use 24-hour urinary sodium monitoring for people on diuretics, outpatients and versus inpatients, refractory versus responsive ascites?
So honestly speaking, I don't use 24-hour urinary sodiums any longer. The only time which I use now is if I'm looking for compliance to dietary advice. That is when I would look at 24-hour urinary sodium. So if I have a high urinary sodium and the patient is still gaining weight, then I know that the patient is eating salt. The other place is when I have a patient with refractory ascites, and if the urinary sodium is less than 30, then I know that the diuretics are not going to work. So that is when I stop. And of course, whenever I have tried the Safi Safet, that is when I always will do a urinary sodium levels.
Well, thank you very much, Akash. It's been really a wonderful afternoon session with a lot of questions answered and about 100+ questions still left for you to answer, which Yogita will be sending you tomorrow. And I think I'll hand over to Dr. Govind for his comments. Govind, please.
Does Manoj have any question, or we go back? Only we have now 1:42. Manoj, you want to ask one or two questions, or we close it? Because this is lunchtime on Sunday. So
152 now questions, total number.
So maybe we take two questions and then we close. Yeah. Manoj, you unmute yourself. Unmute yourself. Yes.
Okay. So, for how long midodrine should be used in patients with refractory ascites? That is a concern because it has some side effects also. Akash?
Yes, sir. So again, I think I would always attempt to reduce the dose. We have data till 6 months. So for 3 to 6 months, I'm very comfortable using midodrine. Very often I've realized that if the liver function improves, which I think today, except for NASH, for most other etiologies, you are able to ensure that the liver function sort of stabilizes over a period of time. So in those patients, you can actually attempt to, and that's my first drug which I attempt to withdraw, also because of the cost. Not only side effects, but cost also is a big constraint. But I don't have a, if you have a, do you have a figure in your mind beyond which you would not give?
6 months or so?
Yeah, exactly. 3 to 6 months is what.
Okay. Now over to Professor Makharia for final comments.
Okay. Thank you. Thank you, viewers, very much. And yes, it's so heartening that even at 1:42, we have more than 1,200 viewers this point of time. So this is really heartening. That's so that the topic having of quite interest to all of us. Thank you, Akash, for making this topic so important. And you brought all the important points which you need to practice in our routine clinical practice. And that's the basic principle of a masterclass, that we want to make masterclass into a change of practice, a kind of forum that we want to improve the clinical practice pattern in our society. And that's have been the focus, and you did so wonderfully, wonderful justice on this topic. Thank you, Akash, again for remarkable lecture today.
Thank you, sir, for giving the opportunity. Thank you so much.
Thank you, Dr. Manoj, for
thank you, sir.
session. It has been pleasure to see you after such a long time, and thank you so much.
Pleasure.
Today's audio was probably we had a couple of feedbacks that today's audio and video were not up to the mark in the initial part of the talk today. So our apology. Certainly, we will go back to our technical team and look at that why it happened. Probably sometimes it happens because of both at the speaker site and also sometimes at other sites also. Certainly, we will look at abilities and let me assume fixed so that we don't have problem in the next master class. The next lecture will be again next Sunday. Again, one of the important topics of biliary stricture. How do you approach a patient who has a biliary stricture, both malignant and benign, but we'll focus on.
Sorry, Govind, your voice is also faded away. Can you just say that again? That part.
This will be a talk on benign biliary stricture. Now, one more thing I want to remind you that ISG have ISG Con 2020 in the month of December 19 and 20. That's a Saturday and Sunday, and for which we have already announced call for abstracts. The abstract site is open, and abstract will be submitted till 31st of August. Secondly, all those who are willing to submit papers for plenary session or young investigator award session, please do send the full paper by email and submit your abstract on the ISG abstract portal. We look forward for your also. Let me thank again Akash and Dr. Manoj again for this participation in masterclass. Thank you, Dr. Saraswat. We want to thank Torrent Pharma for supporting these 4 master classes. Thank you so very much. Thank you, Denise, our technical person, who have been very elegant in telecasting or broadcasting our masterclass. Thank you, Yogita, for all the coordination of these masterclasses. With that, we say bye-bye for the day, and we look forward to see you for next Sunday on yet another topic. Thank you again, and